Hello, I'm Dr. Nelson Stone. I would like to share with you what I have learned over the last 20 years about how to improve your prostate brachytherapy procedure. The first thing to understand is that brachytherapy can be used in all risk groups. You will find that low-risk patients will have a 90 to 95% cure rate, and high-risk patients will have a 75 to 85% cure rate. To achieve these cure rates in patients with low risk, the disease should receive a D90 with I-125 of 190 gray, which is substantially higher than the 145 gray prescription dose that is recommended by the American Brachytherapy Society. A D90 of 190 gray can be achieved by using a prescription dose of 160 as found in the new ACR guidelines, and by covering each slice by the 160 gray. Now, when it comes to the V150, or volume of the prostate covered by 240 gray, it should be kept to less than 50%. The V100 for the rectum should be less than 1 cc. One thing to keep in mind is that the implant should be done with a real-time, computer-based dose adjustment in the OR. What's great about this treatment is that the days of relying on a pre-plan with no live procedure updates are long gone. All treatment planning programs can be used in the OR to represent the prostate, urethra, rectum, needles, or seeds. And these structures and elements can be constantly updated during the implant. Now, for most prostates, virtually all of the seeds are placed in the periphery under the capsule. This includes the seeds delivered through the interior needles, which are placed just under the capsule at the base and the apex. It is important that you do not place seeds inferior to the apex. You need to place the posterior needles in all major grid holes, including the D point or center. The central needle should be placed 5 millimeters from the posterior capsule, but going laterally, the needle needs to be more posterior, so posterior lateral corners are not missed. Make sure you use live planning to confirm low rectal V100. And when placing seeds in the most posterior row, you can move the needle up when reaching the apex, so the last seed is further away from the rectal wall. For your high-risk patients, when combining brachytherapy with IMRT, you need to do the brachytherapy first, and then follow the IMRT in 6 to 8 weeks. By doing so, this will allow completion of post-plan and allow you to make adjustments of dose or margin. When doing combination therapy, you need to be more conservative with the posterior needles or seeds. Keep the V150 less than 50%. If the Gleason score is 8 to 10, when using I-125, D90 should be 130 gray with prescription of 110 gray. If using Palladium 103, D90 120 gray with prescription of 100 should be combined with 45 gray of IMRT. By following these strategies, you can expect the following complications: incontinence, erectile dysfunction, radiation proctitis, and a change in mean AUA symptom score at 10 years of 1 point. For more information regarding radiation therapy, please visit prologix.net.